Hello. He wasn't able to attend today, but he's triple booked. But he wanted me to tell you hello.
Say hello for me.
Okay, everyone. Welcome to the St. Luke's and Idaho Clinicians for Climate and Health Learning Series. Today is our keynote address with an illustrious speaker that I'll introduce in just a minute. But before we get started talking about today, I wanted to talk about our spring lecture series, which I'm super excited for, and starts on January 7th. So just around the corner, we'll have two neurologists talking about brain health and climate impacts. Dr. Brett Andrews and Dr. Beth Ann Mallow will be here on January 7th at noon. We have two in-person speakers that we're going to do sort of a joint in-person online. On February 4th, we are going to have Dr. Matt Burgess from the University of Wyoming talk about how economic growth, climate change, and health intersect. On March 4th, we are going to have two infectious disease physicians talk about leveraging antibiotic stewardship and advancing healthcare sustainability. Dr. Preeti Jaggi and Dr. Shreya Doshi, who I've seen speak several times at national conferences, and they run an organization called Sustainable ID that has really done a great job in bringing infectious disease and antibiotic stewardship to the forefront in climate and health discussions. Then on April 8th, we'll have an in-person event with Dr. Leandro Trossard. Dr. Trossard is a pediatrician who focuses on plastics and their role in endocrine disruption and those impacts on human health. And then in May, if you watched our talk last month and heard Dr. Singh talk about the Choosing Wisely guidelines, we'll have one of the physicians from the Canadian Choosing Wisely guidelines, Dr. Mathilde Gaudreau-Simard, talk about how Choosing Wisely was developed to help reduce low-value care and improve patient impacts. But before we get to those amazing talks in the spring, we've got our year-end keynote speaker, Dr. Don Berwick. Dr. Berwick is one of the leading scholars, teachers, and advocates in the world for continual improvement of healthcare systems. He's a pediatrician and a longstanding member of the faculty of Harvard Medical School. He founded and led the Institute for Healthcare Improvement, which is now the leading global nonprofit organization in its field. He was appointed by President Obama as the administrator for Centers for Medicare and Medicaid Services, where he served in 2010 and 2011. He has counseled governments, clinical leaders, and executives in dozens of nations. He's an elected member of the National Academy of Medicine and the American Philosophical Society. He received numerous awards, including the Heinz Award for Public Policy, the Award of Honor of the American Hospital Association, and the Gustav Leinhard Award for the Institute of Medicine. For his work with the British National Health Service in 2005, Her Majesty Queen Elizabeth II appointed him Honourary Knight Commander of the British Empire, the highest award honored to the UK government by a non-British subject. So with that, please welcome royalty, Dr. Don Berwick.
Thanks, Dr. Sims. It's a pleasure to join you. I've had the chance to be in Boise a number of times, and it's one of the most beautiful places I've ever been, and I really wish I could be with you in person. But that not being possible, it's great to join you virtually. Thanks for letting me do this. I'm going to kind of have pretty much a two-part talk here, and I'd like to leave a lot of time for questions. I'm going to talk first about the placement of the problem of decarbonization and greenhouse gases and global warming in the healthcare industry. Stuff you're hearing about from other speakers, and many of you may already know the details, but I want to be clear about where we are in our knowledge about healthcare's contribution to climate change and global warming, and what we can do to mitigate our impacts and to have more resilience in face of the amount of climate change we already have. So that's kind of the core topic for you, which is sustainability, climate change, and greenhouse gases. But I'm going to go beyond that to my own area, quality of care, and try to link more thoroughly the enterprise of sustainability and greenhouse gas reduction to the broader topic of what quality means in the healthcare world. And to me, it's a rather important example of a large class of what I'll call quality issues that we all in healthcare institutions, clinicians, executives, boards, I think really need to deal with. So they'll be focusing on climate and then focusing on quality and what climate teaches us about that. So the basics about greenhouse gas emissions and climate change, I'm sure you know from this series already. We are losing the battle, and we're already seeing enormous effects on populations, nations, humanity from the climate change that is already underway. And we are just breaking through the agreed upon limits to carbon emissions that have been attempted in multinational meetings and following the advice of the experts, the scholars in climate change. As things are going now, I'm always trying to be optimistic, but there's really room for alarm because we're not mitigating the rate of rise of carbon and greenhouse gases in our atmosphere. The consequences in health terms are quite dire. About 3 years ago or 4 years ago, the World Health Organization issued a statement that said that, in the opinion of that distinguished body, climate change was the greatest threat to human health on the planet. Remember, this is a planet that still has malaria and tuberculosis and HIV/AIDS, surging chronic illness, all sorts of toxins in our environment, and yet the WHO chose climate change to signal as the number one threat to human health. How? All sorts of ways: by changing disease vectors, by introducing heat crises in localities, by reducing the supply of water in countries that could end up without sufficient water supply to support humanity. Extreme weather events, including flooding and storms of a magnitude we have not seen before. Climate warfare, as countries suffer from climate-induced famine and thirst, it increases the risks for combat in fragile zones. Climate immigration, we have not yet seen even the edge of the soaring numbers of people that will need to move out of no longer habitable parts of our planet into others. And we already see immigration as a major issue that we do not yet have the social compact to deal with in creative, productive, and cooperative ways. It's a big deal. Now, healthcare has at least two roles in this. The first, it is a greenhouse gas emitter. We'll come to that in a minute. And second, these new forms of zoonoses and disease and trauma that are introduced due to climate change, we have to deal with. Healthcare is a symptomatic area as people suffer the effects of climate change. And the first realm, which we'll talk about mainly, is us as contributors to greenhouse gas emissions. In the United States, the number that's generally promulgated is that about 8% of the greenhouse gas emissions in the United States are from healthcare. Now, as you all know, that's a complex, it's a simple way to talk about a complex issue because not all sources of greenhouse gas emissions are the same. The usual vocabulary is to look at scope 1, scope 2, and scope 3 emissions. Scope 1 emissions are those that come from what we burn in our furnaces and in our engines. It's the actual act of combustion leading to greenhouse gas emissions. Scope 2 are embedded carbon issues in how we choose to use the resources we have. When we waste food, for example, in the hospital cafeteria, that is an emitter of greenhouse gases. If you follow the chain, a scope 2 emission. Scope 1 emissions and scope 2 emissions are under our control. We can make decisions to burn less, to use less energy, and to look at the embedded carbon content of what we're consuming in healthcare. Scope 3 emissions are not under our direct control. This has to do with the greenhouse gas emissions that are that exist in the supply chain of what healthcare uses. When we use a product or a service, and that product or service is itself an emitter, its own scope 1 and 2 emissions, then those are attributed to us if we could reduce use of those services. That's called scope 3 emissions. We in healthcare, of all of the greenhouse gas emissions that we create, 8% of the total in our country, about 70% of that is scope 3, not under a direct control, but subject to our choices as we decide what to buy, what to use, and as we use our voices and political clout to try to encourage emission reduction in other sectors of our economy. Now, this is all very, very well developed. For really decades, we've had the benefit of scholars and activists who have tried to understand our carbon footprint in healthcare and how to mitigate it. Probably the leader has been this amazing nonprofit organization, Healthcare Without Harm, that I assume your organization is in relationship to. They have a network, a global network of hospitals working on healthcare, on reducing harm from healthcare. By the way, their remit is not just greenhouse gases, it's looking at all sorts of ways that healthcare degrades the health of the environment through the use of toxic chemicals, pollution in water and air, and so on. But they also have a very big footprint in understanding healthcare's contribution to greenhouse gas emissions. I urge those of you interested, if you're not already connected to Healthcare with Harm, to do so. You'll find in there playbooks and advisories and all sorts of materials that you can use to determine how you as an individual or a department or as a hospital can reduce your greenhouse gas footprint. This topic was picked up about 5 years ago by the president of the National Academy of Medicine, Dr. Victor Zhao. Dr. Zhao, in his strategic planning for that next 5-year period of NAM, which is ending about now, put on the screen a number of big bets, very large topics that he would urge the Academy to devote its energies to in its overall strategies. A big issue like equity, a big issue like respect and for science. And at the top of his list was climate change as a topic of interest to the National Academies of Medicine. Dr. Zhao organized and still leads a massive effort under the aegis of the National Academy of Medicine on climate change mitigation and climate change resilience. There is a very prestigious steering group that runs this climate initiative, and you can get on the National Academy's website, nas.edu, and find the National Academy of Medicine Global Climate Change Initiative. A piece of that initiative that I've been very closely involved in for 5 years has been on greenhouse gas reduction, or in the language used over the past few years, it's decarbonizing healthcare. It's only part of the global climate challenge under Dr. Zhao's leadership, but it's a very big part and was the first part, the lead part. Under the National Academy of Medicine work on decarbonization, 4 working groups were established, and each has been very productive over the past 3 years or so in producing reports, guidance documents, and technical assistance that your hospital or any healthcare organization or any clinician can benefit from. The working groups were a working group on direct care delivery. That is, what do we do actually in healthcare as we use tools, methods, approaches to do diagnosis and treatment. The second group was on education and communication. How are we preparing our professionals and helping the public understand what it can do to reduce greenhouse gas emissions associated with healthcare? And finally, and third, a group on the supply chain. That's the scope 3 emissions. So what could the National Academy do in concert with the suppliers of the healthcare system, the people that build buildings, the people that produce drugs, the people that sell us equipment, the scope 3 emissions, a supply chain group. And then there was a fourth group, which I had the privilege to co-chair with Dr. Jonathan Perlin from the Joint Commission and Liz Fowler at the time at CMS. John, Liz, and I co-chaired a group on policy, finance, and metrics whose remit was what it sounds like. What's the current policy environment that either encourages or discourages healthcare from reducing its emissions? Policies, for example, on backup energy for hospitals, does that force them into using fossil fuels more than they otherwise would need to? That's an example of a policy question that results in more greenhouse gas emissions. It was policy finance, which is how does the payment system in healthcare either encourage or discourage reduction of greenhouse gas emissions and decarbonization? And the answer is it goes both ways. There are elements of our payment system that force more volume, more use of materials and procedures which are carbon producers. And then there are elements of finance which could be brought to bear. For example, it's now been pretty well demonstrated through the leadership of a few organizations, such as the Kaiser Permanente on the West Coast, mainly Gunderson Health System, and others that have been pioneers in greenhouse gas reduction, showing that you can reduce greenhouse gas emissions in both Scope 1 and Scope 2 in healthcare without harming a patient. In fact, it helps patients and it saves money, a ton of money. Dr. Jeff Thompson, who's been a leader in this thinking through his leadership at Gunderson, showed millions of dollars of savings through the focus on reduction of carbon emissions and the substitution of renewable sources of energy. And so it's policy, finance, and metrics. The metrics piece has to do with how we know how we're doing. And the answer is we can. Under international aegis, there is a so-called greenhouse gas protocol, which if you Google that, you'll find exactly the measurement tools that allow, say, a hospital to know what its emissions are for Scope 1, Scope 2, and Scope 3. Until the arrival of the Trump administration, which, as you know, has backed way down from reduction in all sectors of greenhouse gas emissions, really getting off the wagon, there has been stewardship in the federal government of a measurement platform, the Greenhouse Gas Protocol, that is under the Energy Star program at the Department of Energy, and it would any hospital, any medical group that plug into that, and by putting its data into spreadsheets, basically can know what its greenhouse gas emissions are. But we don't actually have agreement in the healthcare system about metrics, how we should measure Scope 1, Scope 2, and Scope 3. As I say, tools are available, and the Healthcare Without Harm, and particularly as a nonprofit, has offered tremendous support to any hospital or any clinic that wants to understand what its emissions are. So far, not much progress on that. I think the healthcare system in general is a little bit battered by measurement excess. I mean, hospitals have to report hundreds and hundreds, indeed thousands of data points to all sorts of entities that regulate and study hospitals. And it's exhausting and it's very expensive. And so when it's been proposed to add greenhouse gas emissions or measures of resilience, climate resilience, to what hospitals need to report, there's understandable resistance. And so far that resistance is winning. We have to my knowledge, no real public reporting system that allows you to say, oh yeah, St. Luke's has the following level of emissions compared to a hospital of similar size. I think we need that. I don't think we need it to browbeat hospitals, but it's awfully hard to make progress if you don't have a way to track progress. And so the work on metrics is really an important part of the National Academy of Medicine's leadership. The initial 2 phases of the decarbonization project are now over. On January 1, we begin phase 3, in which each of those working groups now has a new set of initiatives and priorities to pursue. In the case of my working group on policy, finance, and metrics, it will now be changed in its charter. I won't get into the details there. It's not so crucial, but we've produced a number of publications, and more are forthcoming, such as publication on the business case for reducing emissions. Does it actually save a hospital money, and how? The answer is yes, it does save money, and it's pretty easy to describe how. Guidance documents on things like building standards and other things that are related to emissions. Probably for you listeners right now, the most significant piece of that work under the National Academy of Medicine is on the direct delivery of care. As a doctor seeing a patient, as a surgeon doing operations, as a nurse at the bedside, is there anything you can do to reduce carbon emissions to make your contribution? The answer is yes, there is. There's a whole playbook for this on the National Academy website, and it's quite detailed. There are particular things to do that actually make quite a bit difference in that 8% contribution to greenhouse gas emissions. A very attractive one is the cessation of use of desflurane and other anesthetics that have perfectly satisfactory substitutes, but which have an extremely high climate footprint. Desflurane itself is a very, very potent greenhouse gas, and it can be eliminated. In fact, I believe in the UK now, or at least in Scotland, it is no longer used at all by regulation. So just the choice of an anesthetic agent or the choice of a therapeutic initiative, when you understand the embedded carbon, can make a difference, just as driving fewer miles can make a difference. The other form of sort of clinical choice made has to do with excess use of materials. There's a really fine study done, I believe, in Austria of hip replacements, in which the study was of as you go into a total hip replacement surgery and you look at everything used, all the pads and sheets, for sterility, and all of the surgical items that have to be sterilized and re-sterilized, all of the disposables which contain embedded carbon. It turns out that a really remarkably small percentage of what's in the kit is used. I suppose the logic has to do with having things there just in case. But what was shown in this work, and I'm blocking, but I believe it was in Austria, is that a lot of that stuff can just be eliminated. There's no risk at all. You don't really need all that backup stuff. And that has a significant carbon footprint as we then throw away stuff with embedded carbon, or have to turn the sterilizer machine on more because there's instruments that never got used, but the packet got opened. That's a very specific example of a clinical manifestation. Another, of course, has to do with visits themselves. When we can substitute travel with virtual encounters, that's a greenhouse gas emissions saver. And so as much as it's also a convenience to patients and maybe clinicians, this move toward virtual forms of care or reduction of unnecessary visits, for example, is a greenhouse gas reducer. At the hospital level, an obvious example is the vehicle fleet. If hospitals can find a way as promptly as they can to switch vehicles to electric EVs instead of fossil fuel burning vehicles, the decrease in the fossil fuel footprint can be quite substantial. So can using, as in any home, substitutes to fossil fuel burning for heating and air conditioning. Heat pumps run by electricity are far more efficient in greenhouse gas emissions than oil-fired or gas-fired furnaces. And just as my house now has been completely converted over to heat pumps, the same kind of logic can begin to apply in a hospital. So can conservation techniques. What lights are left on all the time that don't need to be left on? The same kind of sensitivity that you want to use in your home to reduce your electric bill and your use of and your emission of greenhouse gases can apply there. The overall theme in that kind of world, as my wife, who's a specialist in this field, says, is use less, green the rest. Use less, green the rest. So whatever energy you're using, the lights that are on in a room that's unoccupied, or the stove that is left on by mistake, or the excess air conditioning, use less. And then what's left over that you have to do, green that, which means making it electric. The move toward electrification, as opposed to fossil fuel combustion, is in healthcare, as in all sectors of the economy, a really important principle, because electric supply can be made green through the use of solar and wind energy, for example, far less carbon intensive than burning fossil fuels. So those are some of the principles under the theme of decarbonizing healthcare. How far could we go? Really far. Jeff Thompson went to zero net energy use at Gunderson. And Kaiser Permanente has had a tremendous track record now of reduction of use, and we're seeing other systems step up with that. You can read the case studies and see what's possible just by getting on the website nam.edu or nas.edu and study the climate change work going on there. It's impressive. Disappointment is that not more are on board. Hospitals and clinics and executives and boards, they have a ton on their plate right now. I needn't tell you. New payment systems, reductions in payment now pending on Medicaid that are just draconian and lethal to underserved populations. Pressures about justice and equity in healthcare, pressures about workforce burnout and the decreasing supply of some very needed professionals. I mean, the day-to-day life of any executive or board or chair in a department today is full of demands. And this idea that decarbonization should be added to the to-do list is not an easy sell. The question arises, well, really? I mean, is it going to make that much difference? I got so much else to deal with. Why should I engage this? And that leads me to the second part of my talk, which has to do with a category of improvements, a category of quality that I'll call commons problems. That term I'm using stolen from the demographer Garrett Hardin, who wrote in 1972 or 3 a very famous paper in Science magazine called The Tragedy of the Commons. And you all are maybe already familiar with it, or you certainly can find it. It's easily available. What Hardin described is a tragic setup that applies to resources that are in a common pool and limited. A common pool and limited. We only have so much clean water to use. We only have so much space to graze our animals. We only have so many, in any category, so many fish in the sea. And at the level of organization of human societies, for many of these they're called common pool resources, it is possible for them to be exhausted. And what Hardin described is the sociology of how a common pool resource gets destroyed. And the metaphor he chooses is a commons in a village. Imagine a village, and it has in its center a pasture that is held in common by all the villagers. Everyone has the right to graze his or her sheep on the pasture. It's a resource held in common, and it's limited. There's only a certain carrying capacity to that pasture. If you put too many sheep on it, they will destroy the grass to a point where the grass can't be repleted, and the pasture will fail. There is, in fact, mathematically an optimal number of sheep in which you're not wasting any grass, but you're not overgrazing. So what Garden said is what Garrett Hardin said was, well, let's imagine a rational person on the village with another sheep. What's rational for that person to do? What's rational is to graze that sheep. The same applies to everyone in the village. Adding one more sheep hardly does anything to the commons, and it does return resource, the sheep growing, to the individual. So the incentives are for each individual to keep adding sheep without limit. And therefore, says Hardin, as people behave rationally, the commons is destroyed. That's the tragedy of the commons. It's in everyone's individual interest as a rational human being to add one more sheep, and that will inevitably destroy the commons. What Hardin proposed in that 1972 paper, I think it was 72, is that there are many kinds of limited pooled resources which will therefore be destroyed. And we see it. We can see it in the form of air pollution, where it doesn't hurt much for an individual to put some particulates into the air, and they get all the benefit of having done that, and the cost is spread among everybody. But when everybody does that, the air becomes toxic. The same goes for pollution in a river, or for a limited fishery when there's a village that has a lake to draw fish from. It was the case for a long time after Hardin's article that this tragedy of the commons was taken to be inevitable, which was Hardin's thesis. Then came along an economist, a woman named Elinor Ostrom. Ostrom began research in the early part of the 2000s, I believe, or maybe a bit before that. She was a professor at Indiana University and became the first woman ever to win the Nobel Prize in economics. And she did it with her work on governing the commons. And briefly, what Ostrom began searching for were communities, collectives that had a common pool resource, a resource that they all could draw on, but that was depletable, that could be destroyed by overuse, like the commons, but which avoided doing that, in which they successfully managed a common pool resource, a limited resource. The examples she chose were all over the world. She found a village in Turkey that had a limited fishery, that is, limited fish supply, and lots of fishermen that managed to draw just the right number of fish out to maintain the fish stock. She found forestries that were maintained without being depleted, even though they were common pool resources. In one of her best books, the one that I found most readable, which is called Governing the Commons, which I recommend to you, Elinor Ostrom showed that there was a way to succeed and that the tragedy of the commons was not inevitable. Now, I won't get into the details. It turned out in her work that there were about 8 principles of action that she found present in the successful communities that successfully governed the commons without depleting it. Those principles had to do with the sociology of cooperation, forms of accountability, and mechanisms for measurement, for example, that supported this community to support its limited pool resource. If we think about health and healthcare, there are all sorts of tragedies of the commons that we encounter in our work as clinicians. One of them is greenhouse gases. Does it make any difference in the long run if St. Luke's Hospital doesn't play ball with decarbonization? No. I mean, it's a few more, tons of carbon in the atmosphere, but that's not what's going to make the difference to the survival of the planet, or to global climate wars, or to the famine and thirst in Bangladesh. No, nor does it make a difference if any hospital in the whole world plays ball. Anyone can be a bystander without doing significant harm. And in other words, it can graze its sheep on that commons. It can put out its greenhouse gases, and it's one sheep. But it's a commons problem in the sense if everybody behaves that way, my grandchildren will be living in a totally different world than they are today, and it won't be better. These problems of the commons need management. They need a way for us to agree in a civilized form that we're not going to destroy the commons. We're not going to add our sheep. There has to be some limit, maybe according to the principles that Elinor Ostrom wrote about. Well, why am I belaboring this? Well, for 2 reasons. One is it is important to decarbonization. I personally believe healthcare, with its gravitas and the respect in which we're held, can be a leader in communities to say, no, don't graze your sheep there. It'll destroy things that we can't care about. And we, healthcare, we're going to take that step. We're going to walk the talk. And even though we don't have to do decarbonization, it won't make that much difference just to us, we're going to show by example that we want to lead governing the commons properly. And I think that that's important to global warming. Unless we have a planet in which nations agree to own their share of this problem, we're going to fail. I am enraged, devastated by the insouciance of the Trump administration in its willingness to just walk away from the Paris Accord, walk away from the problem, drill baby drill, and pour more greenhouse gases into the environment. It's wrong. It's wrong as part of being a steward, a co-steward in a civilized environment. So I feel that the inertia that is out there around the global greenhouse gas emission issue and its reflection in healthcare's 8% of the problem, we need to speak up. And I urge you all to consider the issue of social responsibility and commons issues. That's important to greenhouse gases and climate change. But the real point here, it's important to so many other sectors which have the same property as in commons problems. And that brings us back to health and quality. There are, among nations, within nations, even across cities, enormous discrepancies in health, inequities in health. In my own city of Boston, there's about a 20-year lifespan difference, 20 years of expected life between the wealthiest and the poorest parts of the city of Boston. In Flint, Michigan, it's 15 years from the wealthy to the poor areas. In Chicago, between the Loop, which is wealthy, and the West Chicago, which is not, a 16-year difference in life expectancy. Enormous health gaps. If you read undoubtedly what's somewhere in the mission statement in your hospital, or the reason you became a doctor or nurse, you would, I think, feel that that's a problem. We're here to heal. We're here to restore health. And if there's a gap that big, maybe we should think about how to close those gaps. Now, we have tremendous knowledge about those gaps. We know a ton about why there are such differences between the Chicago Loop and West Chicago, or between Dorchester and Mattapan in Boston and the Back Bay, poor and rich. We know. Also, we know the difference between, life expectancy in Nepal and life expectancy in Paris. It's the same stuff. And we call these social determinants of health. These are the influences in our environment, in our context, that determine how long you're going to live and how healthy you're going to be. And the spoiler alert here is that it's not healthcare. Oh yeah, healthcare has some contribution to these differences, but it's actually quite small, maybe 10% of the variation that's changeable. The other 90% is other stuff. And I'll tell you what the stuff is. And the reason I know it is because I've read a lot about it, and I've had the help of a scholar named Sir Michael Marmot in England. And I'm going to recommend his book to you. The book is called The Health Gap. It was written in 2015. And Marmot digests all of the epidemiologic information about why there's a difference between the Chicago Loop and Chicago, or why there's a 24-year difference, I believe it was, across the city of Glasgow, Scotland. What's going on there? And what's going on there, Marmot says, is five things. Five categories of influence determine whether you're going to live 20 years shorter or longer. And here's what they are. The first thing is how young children are helped in your community. Help to learn, help to thrive, help to bond, help to have proper nutrition. The condition of younger children is a very, very strong predictor of life expectancy in a society. The second is the education system, especially for women, but for boys as well as girls. A society with a strong and highly invested in education system at all levels of age will live longer than a society with less investment in education, wealth being equivalent. The third is the workplace. Is the workplace fair, safe, protected, respected? Are minimum wages at a more than just a small poverty threshold level? Are they wages on which you can lead a good life? And are workers protected either by unions or some other way so that they're respected and helped, not exploited? The fourth category is elders. how are elders treated in society, especially with respect to isolation and loneliness. Societies that have community investment in supports to elders live longer. It's not just the elders that live longer, the whole society lives longer. And then the fifth category that Michael Marmot writes about is he calls it community resilience. It's kind of like everything else. It's nutrition support, nutrition security, food security, housing security, environmental pollutants, criminal justice systems that are restorative and supportive, recreational opportunities, and so on. These characteristics of societies are very strongly correlated with longevity. I'm getting a little battery signal. Excuse me 1 second here. Marmot takes these 5 categories of social determinants of health: early childhood, education, workplace conditions, conditions of elders, and community resilience dimensions, and is able to show that if he knows that about a society, he can tell you how long a society will be lived. The unfortunate fact is that in the United States, we're pretty low on all of those. We're actually among OECD nations, wealthy nations, just about at the bottom for every one of those categories. Our kids are worse off. Our education is less reliable. Our workplaces are less fair. Our elders don't have support through aging policy, and our recreational opportunities, our food security, our housing security are all pretty much at the bottom for the 18 or 20 wealthiest nations on earth. Marmot speculates that the difference between this has to do with how we deal with fairness, whether you feel responsible that kids not be hungry in your town, that people have a roof over the head, that workers not be exploited, that the education system is good for everyone, that elders have company. He calls this fairness. It's a sense of mutual responsibility. In my language, it's a sense of managing the commons, because every one of these are commons problems in which you can buy your way out of the education system and make sure your kids are well taken care of. Are others. You can be the person who makes sure you get food, but do others. We live in a society, inevitably, in which the way we manage problems of the commons, shared goods, determines the well-being of our village. And greenhouse gases are just one example of that. So as you think about a hospital leader, let's say, or a chief of medicine or surgery, or a nurse director, here's the question: what are you responsible for? Is this in your swim lane, to use current jargon? Are you part of the solution to the greenhouse gas problem, to the education in your community problem, to the loneliness problem for elders, of the food security problem for kids? Are you part of that, or is that someone else's problem? As long as we in healthcare regard these as someone else's problem, don't expect them to get fixed. We're too important to society, too well respected. We have too much gravitas, and we're consuming too much of the economy, 20% of the economy, to be bystanders and expect things to get better. So my argument is not just that it may be good for business to reduce greenhouse gas emissions, or that it's kind of nice to do your part. That this is an example of the proper role of healthcare in leading communities toward health, toward well-being, toward safety. That's a big ask. I don't know if hospitals in general would agree with what I said, or if their associations and guilds would lobby for that. But what I know is we have, especially now, a vacuum of leadership around these commons problems. We're acting as if the right way to act is to take care of ourselves, thank you, and let the others shift for themselves. And that's not who I am. That's not what I think healthcare needs to be. And it's not the society that I think in the long run will be healthy and resilient. Dr. Sims, let me stop there. I don't know the best way to manage the questions or disagreements that may surface, but I'm certainly available to have some dialogue if you wish.
That would be great. Thank you, Don. That was a wonderful conversation. Always amazing to see someone with such a fount of knowledge that without a PowerPoint crutch, you can waffle on for 45 minutes with like clear direction of travel and tell a real story like that. So I appreciate the long journey you've had and taking us on the ride for how you got to be such an expert in this field. Um, I think when you talk about this example from the tragedy of Commons, I think one thing that people will feel sort of spurned by or a little bit displeased with that example is how an individual has such a small impact, whereas industry has such a larger impact. You know, if I'm putting one sheep on the Commons, but Amazon's putting 500, um, isn't there some responsibility for maybe not me to switch to an electric vehicle, but for Amazon to be regulated into taking their fleet of 500 trucks and making them electric? I think that it sort of goes back to this idea that the carbon footprint is a way that industry has kind of shifted the guilt of the climate crisis onto the individual who is less empowered to do things. Just curious about your thoughts in that.
Great question, Ethan. Okay, so I say all of the above, 100% with the part of what you're saying. But the way I think about these commons problems, we'll take greenhouse gas emissions, is there's like several levels of activity. One is your own personal decisions. Every time a doctor sees a patient and throws away something that shouldn't have been used in the first place, yeah, that's a small contribution. It's not such a terrible big lift to change that. It's a matter of the same reason when I leave a room, I turn the lights off. And is that going to save the world? No, but I'm doing my little piece of it. Second, there are organizations. And yes, I think even for local pollutants, when St. Luke's Hospital as an organization decides that it's going to be carbon neutral in 10 years or something like that, that's not negligible. That is something. And especially if you are, as you are, an admired member of the society, your leadership as an institution on this Cobblins problem will make it more easier for others to know what to do, create a little bit of peer pressure and incentive to do it. So it's the way a movement works, which is individual players lead other individual players. The third idea, though, with respect to your Amazon comment, is you have one other commons opportunity we do so far as Americans, which is the vote. That is the response of Congress or the state legislature in Idaho to the sensitivities and the desires of the public is real. It's there. It's there and available to you. So I say don't underestimate the possibility of voter mobilization around things that affect your health, in which there are externalities being introduced into your air and your planet by Amazon that you know get together and make it less comfortable for Amazon to do that. That is our work as voters. After all, you know, they're acting only the way Garrett Hardin would predict their act. They're not evil. They're rational. They're in a policy and context environment which makes it rational for them to be excessive, to pollute our air. I'm not saying that's true of Amazon. I don't know the actual numbers. We'll call it Company X, but they're doing what's rational to do, and what we as voters have to do is change what's rational for them to do, and that's another form of individual action in the collective sphere that I think feel very important about. I think for clinicians, by the way, it's the opportunity is bigger. The clinicians tend to withdraw from or sector away from that level of political voice. No. You have a very loud voice if you want to exercise it. You can exercise it in pursuit of higher payment from Medicare and Medicaid. Good luck. But you can also exercise it in terms of protecting your kids and future generations. Ethan, I don't want to use all the airtime, but there's something else I want to mention, just in case there's a listener in the group that wants to take me up on this. It's about Boise. Right now, with federal leadership that's not going to solve these problems, if I can just be blunt, that still leaves a door open for states and municipalities to begin to tackle some of these issues about the well-being of populations and do something about it. Now, the particular opportunity that I'd love to make you aware about is comes from Sir Michael Marmot, this wonderful, gracious, accessible, lovely scholar. Marmot, a number of years ago, began to try to describe a community of Boise, Idaho, that was health oriented, truly working to increase healthy lifespan using the data. And he developed a framework for which what people now call a Marmot community. He kind of rejects that. He's not a narcissist, but we'll call it a Marmot community. And there are 8 principles in a Marmot community, 8 things being worked on by everyone in the community. Right now, there are about 50 Marmot communities in the UK. The very first one was Coventry, England. There are, so far as Michael and I know, none in the US. There's not a single one has yet picked up and said, we can do this. We can be the healthiest city in America. We can improve our life expectancy by 4 to 5 years or whatever you want. And I'm looking for, a solid half dozen of communities in this country that say, okay, we're going to be Marmot communities, Marmot places. And by the way, Michael Marmot will help. I just was talking to him last week. It'd be really exciting if Boise got together and said, we're going to be the first and we're going to show how it's done. And everyone's better off. And everyone's better off whether they vote red or blue. It doesn't matter. This is all about the well-being of our community. So let me just put that on the table and offer you, Dr. Sims and anyone listening, I'm happy to follow up and talk to anybody about it and put you in touch with Marmot.
Yeah, I will share that with city leadership who are often on these meetings. We have a great sustainability and climate action team at the city of Boise that have been great partners for us here at St. Luke's. I think that's a great idea. I was reading something recently about, I want to say it was Copenhagen, but I'm just blurring all Scandinavian cities together in my head now, about how this Scandinavian city was redesigned with this idea in mind. And how it was like very intentionally building a city where cars were not needed.
Yes.
And it encouraged communication between people. So it minimized loneliness. And it was just this very forward thinking, really amazing thing. And I think we get so stuck in the idea that our city is built and it is what it is, and not think that we have the opportunity to redevelop things into what we want them to be, not just deal with things and adjust our lives to how things are. And I think we have so much power to do those things. We just don't enact it.
I agree with you. We have agency here. I think it's probably good. I very much doubt there'd be a single interest group in Boise that would not be better off were Boise to make the choice to be healthy and do it all together. And I probably think it also saves money. Just on sustainability, I do have to mention, since you mentioned Scandinavia, in Denmark, there is an island called Samsø Island, Samsoe. Samsø Island it's actually, I think, a municipality, and I visited it. It's west of Copenhagen. And they made the decision some years ago to be carbon neutral, the whole community carbon neutral. And every little decision that's been made has built toward neutrality, and they're there now. And it's incredible to visit it, to see how much intentionality, agency, just a sense we can do this, can infuse a whole community and get the result. And I think this is a time in America when so many people are feeling isolated, angry, separated, fragmented. It's really great to see places that say, no, we're going to take control of this. And I agree with you. It is in your control, Ethan. It is. And it's bigger than sustainability. It's about the total well-being.
Yeah, I think in these discussions, people have really loved to hear solutions as opposed to hear about the problems as much as possible. And I think you've given us some great resources with National Academy of Medicine, Practice Green Health, Healthcare Without Harm. I sometimes fear that there is so much information out there, though, that we all get sort of drowned in the information overload. Are there 3 top places you would recommend people that are looking to sort of enact some sustainability in their healthcare career to go to?
Yeah, I think I would. Well, this isn't quite what you're asking, but you have this speaker series, and you have forces in Boise together. Get Michael Marmot on the phone, have him be a speaker, and maybe in advance encourage anyone that is willing to read The Health Gap, his 2015 book. I think it would change your dialogue, and you'd have the benefit of the very, very best science. And that would be you don't have to travel to do that. You just listen. And he's not like the only person, but he's really good. He's very generous with his time, and I think it'd be easy. I would say as your comment on Scandinavia should be taken seriously. I think there are municipalities that have taken this seriously, and I believe you could get a mayor of one of the cities that has really focused on sustainability to join you again. Either visit there or get them on this screen and as talk through the details. How have they done it? If you're interested in the Samsa Island example in Denmark, which is pretty impressive, I must say, they have a education building. You can go there and they walk you through everything. And I can't remember offhand the name of the guy that runs it, but again, he'd be somebody probably using Zoom or FaceTime could walk you through a lot of what's going on, and you could just begin to have some ideas. Well, we could do that here, or not. There may be Boise specific issues. For healthcare, my go-to is Jeff Thompson, the former CEO of Gunderson Health. Jeff he's a pediatric intensive care doctor who became CEO and said, let's get carbon neutral, and he did it. And the numbers he's floating about how much he thinks that system saved is quite a lot. He's now no longer at Gunderson, but if you got Jeff, he would help you find a place to see, or again, just come to you and give you some instruction on the strategies he used to achieve carbon neutrality.
Yeah, one thing I've struggled with is this dichotomy of interests, where, like you mentioned, healthcare administrators and executives are just inundated right now. This is not a business that anyone would go into thinking they're going to make a profit.
Yeah.
So few industries face the increased cost of doing business with decreased reward for doing that business like healthcare does. But I fear sometimes that our administration gets so fixated on finances that that's the only thing I can lead with. And I can't talk about the why to me as earnestly, because I feel like that muddies the water, or people lose some engagement if I talk about, the tragedy of the commons example, because I feel like, they have such limited time, and the minute I stop talking about finances being a reason to do it, it becomes deprioritized.
Yeah, well, you're kind of got you're good luck here. I mean, not that it solves the problem. I have a lot of empathy with the overwhelming torrent of demands on leaders today in healthcare, of course, but we have pretty good data on the financial side of this. I personally don't think that's the only reason to do it, but Eric Berzon, Berzon at Kaiser Permanente he's in finance, and for years he's been tracking the benefits in reduced costs at Kaiser Permanente from their commitment to get to zero carbon. As I mentioned, Jeff Thompson from Gunderson is another, and I think that you could put together a pretty solid case that wasting less and using less fossil fuels is a very smart move financially. The other side of it is the workforce side. This is a little more subtle, but generally the workforce cares a lot about this. And if you're looking for ways as an executive, to form a better bond, a tighter bond to the workforce, get them involved in this, and you'll find it's a source of enthusiasm in a workforce that doesn't always feel that enthusiastic. But you're in good company, so don't give up. One other thing, Berzon and Jeff Thompson are examples of people embedded in healthcare systems who have overcome the resistance that you're talking about. And they're really expert. And so they can help, as useful outsiders to help this dialogue occur within St. Luke's or Boise.
Just one quick follow-up to a question I had from the audience that I think is a great coda to the conversation we've had, was in the context of this tragedy of the commons discussion, which I love it's really yes and. It's the individual and the industry that need to be caring about things. How does empowering individuals to make sustainable choices influence feelings of eco-anxiety, especially when people perceive their personal actions can't do it all? And what approaches can help balance individual responsibility with systematic change?
Well, the both and attitude matters. You don't have to make a choice to be an active citizen in large scale change and a responsible individual in small scale moves. And I think that's important. A couple of things that I can just speak personally for me. Well, why would I care? Why do I bother? My kids. And I have a whole generation of grandchildren now, 8 grandchildren, who they're not going to let me off the hook. And I think we have to look them in the face and talk with them about the planet we want to hand over to them. And that, to me, that's right. I mean, that is ground zero. That's exactly, that grabs my heart. I think the enthusiasm of the climate activists, some are too strident, some certainly put people off, but there's a whole very buoyant community of people that are trying to be more responsible together. And we say in IHI, my organization, never worry alone. So once you get into this field, you find a community of effort that can be sustaining and as much fun as your book club. It's people really want to get this done, not just youth, but everyone. I'm sitting now in a house. We have a second house in the mountains, not as beautiful as your mountains, I must say, but still beautiful. And this house, which we built to so-called passive house standards. That's PASSIF, which is the German word for the standards now in Europe for a house that is carbon neutral. And we're just about there. We don't have a furnace, for example. We have plenty of passive solar, and we have active solar as well, and we have wood stove when we need it. We have no fossil fuels in the house, except for one gas stove. And it's the most comfortable dwelling I've ever been in. It's completely cold, whether it's cold or warm outside, I'm comfortable inside. And there's actually it's a better life to be a little bit less wasteful, I think. So anyway, that's my preaching. And I think your question, it's got to be at home as well as out there is a really good one.
All right. Well, thank you so much for taking the time to speak with us, Dr. Berwick. A real legend and inspiration for all you've done in an illustrious career and continue to lead. I'd love to see how you've sort of led on this climate space and incorporated it as a quality marker, because that's something I think we can all agree with.
I think it is, and it certainly can be. And I'll say this, if Boise wants to take me up on being the first and very famous marmot place in the United States, you got my attention. I'll be out there in a minute. Okay.
All right. All right, City of Boise. So thank you everyone for your time. What a great year of learning we've had together, and look forward to seeing everyone back in January to learn about brain health from some neurologists, one adult, one pediatric, talking about how climate is impacting our health. So thank you all for your time and attention, and thank you, Dr. Berwick, for your great wisdom.
My thanks to your colleague, Audrey, who's really made this possible, and I appreciate the great help I've gotten. Thank you. Have a great holiday season, everybody.